Everyone. I appreciate everyone coming in for this lecture. So what I'll be talking about is just more of an introductory topic to stroke. What to look for when people are having a stroke, primarily, and then some treatment options and acute therapies that we have to offer in the hospital setting currently. One thing that's exciting with Ascension Providence Rochester now is that we used to be a primary stroke center where we could handle mostly all types of strokes, but would have to send out other types of interventions. But now with Dr. Wapham here, we can basically treat stroke from the beginning to the end. So I think
Mm,
that's a key addition. So we don't have to delay we don't have to delay time in terms of treating these patients for transfer. They can all be taken care of at our facility. So without any further ado, my name is Dr. Stephen Hardy. I work at the Oakland Neurology Center, which is a subsidiary of Michigan Healthcare Professionals. We now have 6 people in our group, soon to be 7 primary general neurologists, and we round in the hospital and see a variety of patients in the office. I will talk about stroke and go ahead and get started. All right. So, as an introduction, we'll first talk about some epidemiology, just some basic numbers surrounding stroke, some key definitions, and actually the definitions of different stroke types, because different strokes are warranted different treatment options. And what I want to really key in is the signs and symptoms of stroke. So, how to
mm,
recognize someone who could be having a stroke, because our goal is to treat stroke like a heart attack. Everybody knows somebody's clutching their chest, their arm is numb and then up in their jaw. So they could be having a heart attack. We know to get those people to the hospital so they can get that treated accordingly. So we want the stroke patients to be treated the same, because stroke, people don't usually look like they're in despair per se most of the time. So it may not be taken as serious. But I think over the past 10 years, especially, we've been turning that corner to getting these patients to the hospital because of vast communities being able to recognize and know when to get people to the hospital. We'll also talk about some treatment options. And then we'll touch upon primary, secondary prevention, and then answer some questions. Stroke in itself is the 5th leading cause of death in the United States, and most importantly, is the leading cause of disability. With anything out there, this people have deficits that last the rest of their life, and there's a lot of missed time at work and disability payments. Comprehensive cost of stroke in the United States is estimated to be about $34 billion per year, which is a large portion of our healthcare. And one highlight is that 795,000 strokes occur per year. This is according to the CDC, but 610,000 of those, so a vast majority, are new strokes. So people are having strokes more and more, and we'll talk about the risk factors on why that is. So here's a map from the CDC displaying stroke death rates from the year 2011 to 2013 in the United States. You can also there's a bunch of different maps as well in terms of stroke rate over the age of 65, but actually the distribution is pretty similar. So what we'll see is, in this southeast corner of the United States, there's a lot of patient populations that have a higher risk factor for stroke based upon socioeconomic status, availability, and just opportunity to get things treated. And there's a lot of things that can go into why that is, but definitely we see that clustering around that area. And here in Michigan, Southeast Michigan here, we're not too horrible, but obviously the more metropolitan an area you have, the more risk is going to be. So what is a stroke? So a stroke is defined as a pretty much fixed neurologic deficit attributed to an arterial, that's the main type of stroke, or venous or vein, typically lasting greater than 24 hours. Now, there's a lot of variation into that. You can have a stroke and symptoms last much shorter than that, but that's typically, how stroke is identified. Now, there's also some other definitions I'd like to touch upon because we hear this a lot in the community. So TIA, which I'm sure a lot of people have heard, stands for transient ischemic attack. So the main difference here is this is a transient focal neurologic deficit, and we'll get into what those symptoms are, attributed to a blockage in an artery or a vein, but it lasts less than 24 hours, but often less than 30 minutes even. So a very quick presentation with a quick resolution is typically what we see with this patients. A key difference is a stroke has actual damage to the brain. A TIA does not cause any damage in the brain because that area that's blocked unblocks itself before the damage can occur. Now, if we go back and read literature from, I don't know, the 80s or 70s, there's this thing called a RIND, or a reversible ischemic neurologic deficit. This was something they'd say would last between 24 hours but resolve by 3 weeks. We don't use this terminology anymore. It's mainly probably just a stroke, minimal deficit that comes and goes pretty quickly. So mainly the stroke itself and the transient ischemic attack. But when we talk about strokes, there's even subtypes within the stroke as well. So the vast majority of strokes are what we call ischemic strokes. And then the other part of the stroke is a hemorrhagic stroke. So ischemia just means lack of blood flow to an area. So people who have heart attacks have ischemia to the blood vessels leading to the heart. So the same thing can happen to any organ in the body, but the ischemia to the brain causes a stroke. And this is about 87% of all the strokes. So of these lack of blood flow strokes or ischemia, there are embolic and thrombotic, which are the two main ones. Also, people can have vasospasm where a blood vessel constricts itself and causes reduced blood flow because of that constriction. Or there's, say, someone's heart stops, then you have lack of blood flow everywhere. So the lack of blood flow from the heart itself doesn't perfuse the brain. You can cause strokes that way as well. But backing up here, embolic and thrombotic are the two most common types. And embolic means that there's a blood clot that came from another site that traveled, plugged an artery, and then occludes that vessel to cause the stroke downstream. So this can come from the heart. It can come from the blood vessels in the neck, your carotid arteries, or even the great vessels like your aortic arch off of the heart and migrate upwards to occlude those vessels. Thrombotic stroke is area where we call atherosclerosis or plaque rupture in the artery itself over time that just slowly gets to a point where it closes off and then causes the stroke downstream as well. So this can be seen with a lot of high blood pressure, high cholesterol, diabetes that just cause the arteries to slowly clog over time versus a clot coming from somewhere else in the body to clog the artery. Now, changing tunes, the hemorrhagic stroke is the opposite of an ischemic stroke. So instead of lack of blood flow, you have too much blood. So this occurs by a rupture of a blood vessel that bleeds into the area, and that blood collection into the brain causes the damage of a hemorrhagic stroke. This isn't an aneurysm like we all think. It's just a small billowing of a vessel that can rupture and cause blood accumulation in the brain. So here's a cartoon depiction, just noting the differences between a hemorrhagic stroke and ischemic stroke. So you see the blood vessel here where there's a hole in the artery, and then the blood products rupture and cause damage into the brain tissue surrounding that area in here. Versus an ischemic stroke around the same area, you have this. This could actually be a blood clot that migrated and plugged this area that halted blood flow downstream. So without that blood getting to that area of the brain, it's going to cause a stroke. The yellow parts here can be an example of atherosclerosis or slow growing thrombosis, where it just narrows off and narrows off and narrows off, and then it can actually pinch off. But it's kind of depicting both parts here. But that's the lack of blood flow versus hemorrhagic, which is too much blood flow. Now, here are actual depictions on what we call a CT scan, or CAT scan is commonly known as, where you can see the differences in ischemic and hemorrhagic strokes. So this white stuff here is the bone in the patient, and the light gray to dark gray is normal brain tissue. But you can see on this side where the arrow's pointing, it's much, much darker. So that's a lack of blood flow type of stroke. This is a drastic depiction. I mean, this is a large one, but this is a lack of blood flow stroke and how it looks on a CAT scan versus, and this is just the nature of CT and how things look, but blood products appear bright on a CAT scan. And you can see that the blood has rushed into this area and caused disruption and a little bit of swelling around there as well. So just in terms of what they look like on basic images that we obtain, that's how we can differentiate between the two. Okay, so signs and symptoms. So what are we looking for when people may be presenting with stroke-like symptoms? So a stroke usually occurs pretty rapidly. The general theme is that someone presents with a symptom and it has maximum intensity rather quickly. That's a fixed deficit, and can improve with time, but it's usually acute and rapid at onset. So symptoms can include weakness, numbness or tingling, or facial drooping or drooping of the face. So this is usually on one side of the body. That's the hallmark sign of a stroke. One side of the brain controls the opposite side of the body. So if someone had left-sided weakness, left-sided numbness and tingling, or drooping of the face on the left side, one would be concerned that there could be a stroke occurring on the right side of their brain. Excuse me. The facial droop commonly seen in stroke presentation usually, most nearly always, involves just the lower portion of the face. So people can close their eye, they can open their eyes, wrinkle their forehead, but when they try and smile, the lower part is impaired. People may have heard something called Bell's palsy. That's a different type of drooping of the face that involves the entire face. But in my opinion, if you see anybody with any drooping of the face, you treat it as a stroke until proven otherwise. So getting them to the hospital and getting them assessed as soon as possible would be the gold standard. Now, slurred speech can also be a hallmark sign of stroke. The speech is more of a mechanical issue. So if their face is drooping on one side and they're trying to speak, we don't have the symmetry to make it sound smooth. So it's going to come off garbled. And that's why people have the slurring of their speech during a stroke. It's more of a mechanical issue. Versus there's something called aphasia, which is more of a language problem where people struggle to either get the words out. They know what they want to say, but can't really get the words out. And they may seem frustrated. They may stop or take deep breaths because of that frustration. And that's more of a language problem because of a particular area affected in the brain. Also, they could just not understand what anyone is saying to them, and they can come out with something called a word salad where they can speak well, but the words just don't make any sense and they just string them together, and they are unable to communicate or follow directions because of that. So that's more of a language problem due to the brain, and slurred speech itself is more of a mechanical issue because of most likely a drooping of the face. Now, and the inability to speak or understand is what I was getting at with the aphasias. Now, vision can also be affected with strokes as well. You can have double vision in some types of strokes, but even more commonly, you can lose vision in. Oh, I'm sorry. I'm sorry. Oh, I didn't know if someone had a question. Maybe not. Maybe that was just background noise. Okay, sorry
Yeah, I
about
think somebody was just having problems with their um, with their audio, but I think it's okay now, Dr. Hardy. Sorry about that.
Okay, no problem. Okay, so back to the vision. So the vision is usually lost in both eyes to one side of the world. So if someone covered up one eye, you'd still have a loss of a vision deficit to one side. And if you switch from eye to eye, you still have that same visual deficit on that side. Typically, I don't want to get too detailed, but typically, if you cover up one eye and the symptoms go away, it's usually just an eye problem. But again, if you notice any vision problems, if someone's communicating to you that they can't see to one side or in general, that's definitely should be taken as a possible stroke as well. Other signs and symptoms, difficulty swallowing. So if someone has significant drooping of the face or difficulty moving their tongue, or other areas in the back part of their throat, those muscles not moving in unison can definitely cause difficulty swallowing as well, or choking episodes. So those are a lot of the main symptoms of stroke. One thing I'll throw in here too is if people have pretty significant size of the stroke, you can often see people's eyes deviated towards one way. They'll have trouble looking to one side. So they'll just say if there's just looking to the left, you ask them to look to the right, they may ignore one side or unable to move their eyes to the opposite side as you cue them. So eye deviation towards one area can be a sign of a stroke as well. And then also that neglect of one side of their body too. And then if someone's just not as awake or alert, they have a drooping of the face or their eyes are deviated, that level of alertness you can see with strokes as well. Typically, people do not lose consciousness. It'll be very rare, but that could happen. But we don't see that typically. And then lastly, rarely people can have symptoms on both sides of the body. There's a certain part of the back deep part of the brain that could potentially cause symptoms on both sides during a stroke, or stroke to your spinal cord. Not to get too technical, but from a brain standpoint, we typically don't see both sides of the body involved. Okay, so there's a lot of acronyms out there in terms of what to do. So if you see anyone with these symptoms, so say someone's slurred speech or they're dizzy, and you want to kind of assess them in the community, there are a few acronyms out there, and I'll kind of go through them that you can assess. There's one called Be Fast, and they all iterate the same thing, just different ways of saying it. So the B stands for balance, the E stands for eyes, F for face, A arms, speech is S, and time is T. So balance is someone having a coordination problem, falling towards one side, especially. That could be a sign of stroke. The eyes, are they losing vision to one side? And I'd also even throw in there, are their eyes deviated to one side only? So that's something I would look out for as well. In the face, mainly are they having drooping to one side of the face? So, to reiterate, strokes usually affect one side of the body. So that's a hallmark sign. The arms, so you want to assess if they can lift their arms up. Is one side not able to lift up as high as the other? You can assess their legs as well, for that matter, and see if they're not moving one side in comparison to the other. Speech, is the speech slurred? Are they having that struggle to get the words out? Or are they just having a word salad, like I say, or just saying a bunch of things that don't make any sense? And then the last step after you assess that is time, because time is brain, as we say. So you always want to call 911 as soon as you suspect that someone could be having a stroke. And I'll get into why that's important in just a second. There's another, the oldest one I can think of is called fast. They just don't incorporate the dizziness and the vision. So F is for face, A is for arm or leg, even speech, and then time, right? So just same reiteration of similar things. There's one called faster as well for face, arms. The S here is for stability. The T is for talking here. The E is for eyes, and then react. So like the time and the other ones, you want to react, call 911 as soon as possible. So fast is probably the easiest one to remember, but be fast, faster, do incorporate the dizziness and the eyes and the vision. So definitely you want to be aware of what symptoms of stroke could be. Okay, so Now, we know how to recognize someone who could be potentially having a stroke. Sorry, my charger came out. So we could be potentially haven't seen someone who's having a stroke. So what do? So we bring these patients to the emergency department, and time is brain because 22 billion neurons are in the brain, and we lose 1.9 million neurons each minute during a stroke. So that's a significant amount of nerves and synapses and networks within the brain that communicate to each other to have us go on our daily lives. So that's why we want to do this as fast as possible. So there are two main things we can do in the emergency department. The oldest one is back in 1995 that was approved. It's called TPA, which stands for tissue plasminogen activator. So this is more of a clot busting medication because remember, this is only for ischemic strokes. The hemorrhagic strokes, we cannot do this for. So for the ischemic strokes, which is the lack of blood flow, we want to bust up the clot that we think is clogging the artery so we can restore blood flow and reduce the level of effect of the stroke. So they did a study that people who receive this medication have about 33%, I think technically, less disability than people who didn't get the medication in the trial at 3 months if they met the criteria. And there's a certain set of criteria that we have to abide by to make sure it's safe in these patients. But obviously, getting people to the hospital for us to make that assessment and determination is best in the community. Now, you want to get people there ideally within a 3-hour period. But they've done studies even afterwards that we can extend that window to 4.5 hours. And it's very important to establish when that person was last seen normal. Because you can walk into a room, see somebody with a facial droop and their arms not moving on that side, and say, hey, I found them at 6:30 p.m. and that's when the stroke happened. They could have been down for hours. And then we give them a medication that could bust up the clot, but it could have a deleterious effect as well. So discovery time is important, but also when was that person last seen their normal self, unless you were with them and you saw the change right in front of your eyes. Okay. They're also doing studies in the works if we can administer TPA in extended windows, if we do certain imaging criteria at certain hospitals with these fast-acting MRIs, if we can confirm certain areas that are still salvageable. So they're doing more studies to try to make it widely available. The TPA is typically better for the arteries. If you think of the blood vessels as a tree, and the branches off that main trunk, kind of those third, fourth generation branches that we can bust up that clot. But we usually see more of a reaction in those patients. But we know that very large embolic strokes or those blood clots traveling from another area to clog a big artery, we need to do something about that as well. So they did a bunch of initial studies trying to go in through the groin like they do with someone with a heart attack to go in and stent the artery or take out the clot. So they're doing the same thing in the brain. So they just reroute it and they take the wire, then they go up the neck, and then they shoot dye so they can see what's going on in the blood vessels real time, locate the blockage, and then they can go in and suck out the clot. And then you're limiting the lack of blood flow that's going to basically damage other areas of the brain. So we call that endovascular treatment, and the technique is called a thrombectomy, where they go in and remove those clots. Initially, it was approved for 6 to 8 hours after the onset or last seen normal from a stroke, but recent studies within the past 2-3 years have extended that window to 24 hours. So it's still important to get people to the hospital as fast as possible whenever you notice a stroke, because there's always special scenarios when things could possibly still be done. And now that we have the comprehensive center at Ascension Providence Rochester Hospital, we can take care of these patients and do that as quick as possible. Now, if someone wakes up with a stroke, then you obviously don't know when anything happened. So with these patients, they wouldn't necessarily be a candidate for TPA. They're doing some studies to see if that could be possible, But right now, these patients would only be a candidate for thrombectomies, where they'd go in and take the clot out physically in the certain patient population that meets criteria for that. Okay, so when we're in the ER, I showed you pictures of these. So we get a CT of the brain, and mainly you want to make sure there's no bleeding in the brain, because those patients would not be a candidate for any of these therapies mentioned in the last slide. Um, MRIs can be done quickly at certain centers. Usually the tertiary care centers, where they have a lot of the equipment to get it done, but CT is just fine. Now we do CTAs to look at the blood vessels and the picture. And then also there's something called a CT perfusion study. So now these are mainly used for those thrombectomy or endovascular patients. The CT brain is there just to make sure there's no bleeding if someone can receive TPA. So the CTA, which stands for angiography, is the A, or the blood vessel study. We're looking for that large vessel occlusion or that big clot that's migrated and clogged an artery, so we can go in there and take it out. So we want to actually visualize that before we do it. And then there's something called a perfusion study, which looks at areas around the main area that's involved that could still be salvaged, because with the unique design of our brains, one area of the brain is usually supplied by multiple different blood vessels from different areas. So if you block one area, you may significantly impact the central part, but you're still receiving blood flow on the outer parts, but they're not large enough to keep that up for a long period of time. So you want to restore blood flow as long as possible. And that's why these techniques work pretty well for the right patient. Okay, now here's some pictures of these various images. So these are MRIs. This is a specific window in the MRI that looks for strokes occurring right now or within the last 2 weeks. So the white areas are the areas depicting strokes. This type of stroke will be seen from like a hypoperfusion, or someone not getting blood to the entire brain. This is a stroke from the back part of the brain, the blood vessels there, and this is your main area of the brain that's usually affected from the what we call anterior circulation. So the blood vessels that supply this area of the brain, you can see here, all these white kind of finger-like projections are arteries, and you can see on this side that the arteries are nice and robust. And then here on this side, you see a tapering off and darkening of these arteries here. Now it's very dark here, but you may see a little bit of flow otherwise because of that collateral flow I was discussing before. But this is what it looks like when we see something on angiography that may be amenable. Same thing depicted here, blood vessel on this side, but you don't see anything here, so we know there's a blockage. And again, depicting the same thing. So with thrombectomy, here's an example of what they're doing in the endovascular suite. So what they'll do is put in a needle in the groin and take a catheter wire and feed it up the artery into the area of the brain and shoot dye. And then by looking at the dye, you can see where it goes to look for blood flow. So if you look here versus here, you see the blood flow nice on this side, but over here it's nice and tapered off, and there's a blockage right around here. And same thing depicted here. You don't see these arteries filling robustly, but afterwards, these C and D are after the thrombectomy. You can see blood flow is restored. And this is what the thrombectomy device looks like. So it's basically thin as you put it in the artery, and then the surgeon or the neurointerventionalist will deploy the device where it stents open, and it basically goes through the clot and past it, and then you open it up and it traps the blood clot in this mesh wiring, and then slowly pull it out, and then you take the clot out of the brain. And here's an example of some clots that have been retrieved. And you can think this small area here can actually clog a large portion of your brain. So taking that out, restoring flow, as you can see here, can save a lot of damage and disability, because when we didn't do this before, you just have these areas die out, and then people will be more severely disabled than if we take the clot out in appropriate timing. Okay, so we talked about how do we identify someone having a stroke, what we do in terms of treatment in the emergency department, and some of the examples of that. So what do we do once all of that's done? We try to figure out, well, what caused the stroke itself to begin with after we treated, or even for people who weren't amenable to those treatments. So we put people on heart monitors to make sure they're not going any abnormal rhythms. There's something called atrial fibrillation, which is the main heart abnormality, rhythm abnormality, I should say, that can cause strokes because the top part of the heart quivers. And when you have blood stasis, not moving, you can have it pool, and that predisposes clot formation. And then once that clots, it can go down and get pumped up and clog an artery. So people who do have atrial fibrillation, they usually put on blood thinners if they're the right candidate to help thin the blood out. We do carotid ultrasounds. This is putting gel in the neck to kind of look at an ultrasound report to see if there's a significant amount of blockage on the internal carotid artery, which is the main artery feeding the front portion of the brain. So if there's more than 70% blockage on that side that's symptomatic, then they would be amenable to recanalization or carotid endarterectomy, or sometimes for certain patients with risk, they can do a carotid artery stent. We also do echocardiograms, which is an ultrasound of the heart, looking for what we call patent foraminal valleys, or this is a hole in the heart that we all have in utero, but it closes up. But 25% of the population actually can have this. But the theory is you can have a blood clot on one side that goes through this and gets pumped up to the heart that can cause a stroke as well. Or is there an active blood clot we can visualize in real time in the heart that may be ready to get pumped up? So that's what we look for on the 2D echo, and make sure the heart's pumping well. Excuse me, there's something called a TEE, which stands for a transesophageal echocardiogram. So this is an ultrasound that goes down the throat. It's more like an upper GI or endoscopy study, but they go down the esophagus or the throat. They turn the camera to look at the back part of the heart and the chest, because that area looks for a high yield or area or a high propensity area of the heart that could have blood clots. And it's a better study to look for this PFO, or the hole in the heart, as well, because these can be closed off to prevent further strokes. And then we do labs, so checking glucose, checking cholesterol. Some people could have potentially clotting disorders that can predispose them to clots as well. So that's what we'll do in the hospital or in the office to kind of look for what the reason was people had stroke. Now, what do we do after someone has a stroke? So say they came in, maybe they didn't meet criteria for TPA or thrombectomy, or they even did get that. So we look at their residual deficits, and then we try to rehabilitate that area so they can get to a better level of functioning, get back to work, and be a contributing person in society. And, that can be very depressing that, you're unable to do what you normally did, and that can lead to another host of problems as well. So there's physical therapy, occupational therapy. Physical is the strengthening, occupational is kind of learning to overcome the deficits you have and learning how to deal with it. There's different settings you can get this done at, but really the main focus is working on those other areas of the brain that aren't affected. We call that plasticity, which is usually seen in younger people, but some areas of the brain can hopefully what we call pick up the slack of the area that had the stroke, so you can regenerate and rehabilitate that area that's affected in the body with whether it's weakness or numbness or speech issues. And then speech therapy, they work on swallowing, syntax, language, comprehension, and expression to try to do the same thing the physical therapy is, just with the language center. And then those risk factors we talked about, high cholesterol, blood glucose, blood pressure, you also want to mitigate those risk factors as much as possible to prevent anything in the future from happening. Put people on blood pressure medication, diabetes medication, cholesterol medications. Typically, people leave the hospital with an antiplatelet, which makes the blood vessels less sticky, things like aspirin or Plavix. And then a cholesterol medication or statin which has high evidence to reduce thrombus formation or clot formation that can cause stroke as well. It has some antioxidant properties too. So again, these are the risk factors we also want to modify, but there's some things we can't really do. So one risk factor is aging, so and family history. Those things we can't change, but we note them and become more aggressive with secondary stroke prevention if that is the case. But smoking cessation, weight loss, and then the atrial fibrillation, putting people on medications for that as well. All right. So again, I kind of hinted towards this already with the secondary stroke prevention. So the antiplatelet therapy, Plavix. Typically, we start with an aspirin. If someone's on aspirin already, sometimes we'll do dual antiplatelet therapy, which is aspirin and Plavix together for about 3 months, and then you can go to one monotherapy thereafter. There's no big evidence that one works better than the other, but that's kind of the general practice that we have. There's an older medication called Agronox that used to be used a lot, but can cause a lot of headaches, and we don't really use that much anymore. There's some updated studies that I think it went head to head with Plavix, and Plavix definitely showed superiority. Oops, sorry. And then the cholesterol goal, we want the LDL, which is the bad cholesterol, we want that to be less than 70. So typically anybody without any risk factors, 160, 130 could be acceptable, but we want that even lower than normal for people who have already had a stroke. We want to get that less than 70 using a statin medication. Statins can classically cause muscle fatigue or muscle aches. There are many different ones that can be used, but there are other cholesterol lowering agents that we can definitely still go with, or fish oil naturally, to try and reduce that cholesterol if there's an allergy to statin therapy. There's anticoagulation as well, which is different than antiplatelet. So when I say blood thinner, I'm typically talking about an anticoagulant, things like Coumadin. There are newer ones where you don't have to monitor blood work like Coumadin. Xarelto, Eliquis is used a lot for secondary stroke prevention with atrial fibrillation patients. There's Pradaxa, a few other new ones as well. But this is typically seen for atrial fibrillation patients, or if you actually visualize an active blood clot in the heart, because you want to stabilize that so it doesn't get pumped up and cause any other strokes. And then obviously rehabilitation that we touched upon earlier. All right, and closing out, just wanted to talk a little bit about hemorrhagic stroke. So obviously these people would not be a candidate for TPA, because if you're bleeding, you don't want to thin that blood or bust up clots, because you're just going to make the bleeding worse. So these people would not be candidates for TPA. But mostly these hemorrhagic strokes are caused by high blood pressure. If you think of the pressure building up in the artery, it can only expand so far. You can cause small little tears, and obviously. Hello? No, I'll disregard. And then, and then that can actually cause a tear in the blood vessel to cause that actual bleeding. There are some other things that can cause bleeding in the brain. Tumors notoriously can cause bleeding in the brain. Vascular malformations, where you can get entanglements of blood vessels and different pressure, high pressure, low pressure systems that aren't really supposed to be connected to each other, causing these bulges and bleeds. And certain medications like blood thinners can cause bleeding as well. So what we do is control the blood pressure aggressively. There are parameters that we set in the ICU setting that prevents the blood from getting any worse. And then, like a bruise anywhere else in the body, as things are stabilized with time, the body will absorb the blood products and clean things up, but there's always going to be that scar in the brain because of the blood getting into that area. Okay, and then primary stroke prevention, a little bit different. This is before you have a stroke. So what do you want to do in general to stop? We don't want to be reactive, we want to be proactive. So what can we do now to prevent us from getting a stroke currently? So kind of cliche things, healthy lifestyle, good diet, exercise most days of the week, things that we do for our heart and cholesterol and blood pressure to begin with anyway. Mainly you want to prevent or successfully treat other comorbidities or chronic diseases, high blood pressure, high cholesterol, diabetes, peripheral arterial disease, coronary artery disease. So mitigating these risk factors up front will help prevent having a stroke down the road. Now, these are all risk factors for a stroke, but if we control them as best as possible, we can prevent that from happening. Tobacco cessation, tobacco can cause numerous things, heart issues, definitely blood vessel issues, aneurysm, bleeding. So tobacco cessation is probably the number one or easiest thing to potentially do, get rid of that we're doing to ourselves. And then aspirin, there was a study that came out saying that people shouldn't take aspirin just in general to prevent heart attack, stroke. Actually, that study highlighted people with no risk factors. So if you're somebody who has this profile, I definitely would recommend an aspirin, 81 milligrams, or maybe aspirin daily to prevent strokes from happening. So if you don't have any risk factors for stroke, there's no point in really taking an aspirin with that recent trial, but I just want to point out that it is for that scenario. All right, and those are my references, and I guess I'll stop. What time is it? It's about 15 minutes for questions.
Okay, wow, that was a lot to learn, Dr. Hardy. Thank you so much. It was riveting. I had a question, if I can start. Years ago, my father was at rehab, and he started showing the signs of a stroke, and his physical therapist gave him an aspirin. And they told us at the time, and this was years ago, but they told us that if it's a stroke, it'll slow down the symptoms. Does that have any truth to it?
Yeah, one thing you want to make sure is too, though, I wouldn't fault anybody for doing that, because yeah, you want to kind of make the blood unsticky. So if there is something clotting up, that will help not make it as sticky to prevent the stroke from happening. One thing we want to make sure, though, is it's not a bleeding type stroke, because if you give like aspirin,
Right.
especially high doses, it can make the bleed worse. So, but typically people do that in the field. I wouldn't have a major problem with that, but if you're going to send them to the hospital anyway abruptly, I would just wait until they get there, and then we can get the CAT scan gets done. You should see the criteria. There's certain parameters set that the CAT scan's done and interpreted within 10-15 minutes of arrival. So things get done rather quickly. So we can make sure there's no bleeding, stroke, and if there's not, then they do administer aspirin if they're not going to be a TPA candidate.
Okay. Okay, Judith has a question. Judith, do you want to unmute, or would you like me to read it?
You can read it.
Okay. Okay, so she said it's recommended a low dose aspirin if bad cholesterol and or hypertension. So I think the question is a low dose aspirin recommended with bad cholesterol and or hypertension?
Yes. So even with one of those risk factors for stroke, I would recommend going on a baby aspirin, especially over the age of, they used to say 55 for men, 65 for women. It's changed a little bit, but with that risk factor, I would definitely do that over the age of 60 for sure.
Okay. And Marie has a question. She said, would you mind going over the symptoms of the vision problems as a sign of a stroke again, just quickly?
Yes, be happy to. So vision can be a few different things during a stroke. The main one that I would see mostly is loss of vision to one side of the world. So like I said, one side of the brain controls the opposite side of the body. So in the vision center, if it's affected, you're not going to see to the opposite side. But if you cover one eye, you should still have the same deficit to the same side of the world if it's going to be a stroke. So say someone says, I can't see to the left, have them cover one eye. They still can't see to the left, uncover, cover the other eye, and they still have the same deficit. That's concerning for a stroke. If you cover one eye and it goes away completely, typically it's just that one eye that was covered that was affected. But I'd still, come in and make sure we get that assessed to tease out those details. The other vision issue could be double vision. So if someone's seeing two kind of stacked side by side or top to bottom, there are areas of the brain that can be stroke related with that as well. The main thing there is just kind of constant no matter what you do. It's not like you kind of whacked your head or you're dizzy and you have it here and there. It's just pretty constant. And sometimes you can even see if you have them look up, down, left, right, their eyes aren't moving in unison. So that could be a sign that there's a stroke going on as well. And then the last point with the eyes in general, if you see their eyes physically deviated to one way and it's stuck there, that could be a sign that someone's having a stroke as well. So the main is the kind of vision loss to one side of the world, but the other two would be double vision. And then thirdly, the eye deviation.
That's great information. And I think it's really important for everybody here, from the message that I heard from you, was timing is very important. So if you have any of those vision problems, don't sit back on the couch and say, let me see if I feel better in an hour or two, because an hour or two can make a big difference.
Yes, I can't. And my point is too, compared to a heart attack, if someone's clutching their chest and not breathing, the universal human response is, oh my goodness, call ER and get them to the hospital. If someone's just saying, oh, I can't really see to one side, they don't look like they're about to die, right?
Right.
So oftentimes we neglect those symptoms. By the time you get there, it's too late and you could have a disability from that. So that's why the education is changing a bit to get people to the emergency room quicker, and things like this to educate the community on what those signs are so we can recognize them and get them to the appropriate setting.
Yeah. Latessa, you have a question, and then Dennis.
Yes. Hi, doctor. This is really great. Thank you. And thank you, Marianne, for putting it on. I was wondering, do you have any do you recommend any supplements for brain health prophylactically? Any certain supplement like magnesium or anything that's out there, anything to keep the brain healthy?
I think I heard you mention fish oil.
Yeah, in terms of cholesterol reducing in general, well, fish oil can be used. I mean, there's a lot of data behind that. But in terms of brain overall health, there's nothing I would say that's, like a double-blind placebo-controlled trial that we can say, do this and you're going to protect your brain. But there are a lot of supplements out there. When you think of the brain or nerve health, brain and nerves love fatty acids and they love B vitamins. So basically most of the things you see out there, like if you think of, we're getting off, I don't want to get too far off topic, but like dementia, you have Prevagen and other products out there. They're all just different formulations of fatty acids and B vitamins. Theoretically, it makes sense because that's what the brain uses to make energy and metabolize and keep its energy going. But I can't give a formal recommendation of doing those things, but it won't hurt.
Okay, thank you.
You're welcome.
Okay, Dennis?
I have a major concern about stroke avoidance because of my hypertension. Is hypertension a key factor in the stroke occurrence?
Yeah, well, mainly uncontrolled hypertension. If it's controlled, then it's still a risk factor, but if you have it controlled, it won't be as big of a risk. But uncontrolled hypertension is one of the leading causes of people having strokes, definitely. And
what do you mean by controlled hypertension? What do you mean by that?
So if you have high blood pressure, you're on medication that brings the blood pressure less than 140/90 or as close to 120/80 as possible, then your risk factor for having a stroke is significantly lowered. So controlling it, meaning reaching those parameters.
Well, my average is 160 over 78. I take it every day, and I'm taking 4 meds for hypertension.
Okay. Yeah, I mean, everyone is different, but getting it under, I don't know if you can talk to your internal medicine or family medicine doctor or your cardiologist, but getting that systolic, the top number, less than 140 at least, would be more beneficial. I don't think
think so
it's, say it again.
I think so too.
Yeah, yeah. Now, once we get to the 180s, 200s, I mean, that's where we really see when people are in the hospital, that's when they're having strokes. But, you don't want to, because the more you're at 180 or 160 above 180, then if you have a spike, you're going to be in that 200 range versus if you're 140, 120, and everybody has an up and down, but your up won't be as high, and then that'll reduce your stroke risk factor. So yeah, getting that down a little bit would definitely be highly
I'm
highly
focusing on a low sodium diet.
good. Yeah, so the sodium reduces the water retention, and then that increases the blood pressure the more fluid you have in the blood vessels. So getting that out with the sodium definitely is a good idea.
Good. Okay, Judith asked, is there a specific dosage of fish oil that you would recommend?
I would say I think they pretty much come like 1,200 milligrams. So I probably do that per day. That's what I see most of my patients on. Yeah, I wouldn't really give another dosage, but yeah, 1,200 would be pretty typical.
Yeah. And there's different products, just so you guys know, for fish oils. And do you have one that you recommend? Because some of
I-
them smell really bad and some of them don't.
Yeah, I don't have one that I would specifically recommend. I try to get most of mine from salmon, if
Yeah,
like a
okay.
good way to get it. But yeah, I wouldn't, if you eat like a Mediterranean diet and a lot of fish, and you don't want to
Okay,
load up on fish oil too. But I don't have a specific product. No.
okay.
So DHA and EPA components of your fish oil are going to be important for the omega-3s.
Yeah, I mean that's all very important for sure. So you want to get the different fatty acids, like I said, because that can help with brain health overall, theoretically.
Okay. Does anybody else have any questions? Okay. Dr. Hardy, I cannot thank you enough. This was wonderful. Yes, we're getting hearts from Latessa, clapping and thumbs up. It was
Excellent.
really like couldn't stop listening or watching. It was very informative. So thank you very much. I will send everybody a link to the recording of this video so that you can share it with your friends and family, because I learned a lot tonight and I know that more people should know this information. So after I send the link out, please share it with everyone you love, because we all want to prevent strokes.
Yep.
All right. Thank you, Dr. Hardy. I hope we can have you back again.
Oh yes, I love these forums, and I appreciate everyone for coming, asking excellent questions. So happy 2021, and
That's
see you in the
right.
future.
All right.
Thank you.
Thanks. Good night, everybody.
Good night. Thank you.
Thank you.
Bye-bye.